So welcome everybody. I'm Jen Kovich-Bordnick. I'm the CEO of the eHealth Initiative and Foundation, and I want to welcome you today to our program. As I mentioned, we've got a really fantastic crew with us this afternoon. Dr. Matt Lambert, who is the CMO of Curation Health. We will be joined by Dr. Steve Waldron, who's the VP and Chief Medical Information Officer of the American Academy of Family Physicians, and Mike Arcoletto, who is the CIO of HIPAA and Information Security Officer of Mount San Rafael Hospital. So three real excellent folks who are going to speak to us about technology and physician burnout and what this looks like in the real world today. We are going to have a few brief presentations and then a really interesting panel discussion we've got planned for you today, but we do want to hear from you. So please feel free to put your comments in the Q&A box. We appreciate comments, we appreciate questions, thoughts, anything, any kind of reactions to what the conversation is and in the direction we're going. Please feel free. We want this to be as engaging as possible. Next slide. If you're not familiar with the eHealth Initiative, this is just a sampling of some of the groups that we work with. We have a pretty broad membership and leadership. We actually have a leadership council that runs the majority of our activity and programming. And you can see it's a pretty broad brush from across different stakeholder groups, payers, providers, vendors, academia, consumer groups, wearables, all kinds of different organizations working together, trying to figure out how do we connect the data that's out there to transform care. Next slide. We do primarily education, advocacy, and thought leadership. If you didn't see your logo on that slide before and you're not engaged with us, you really need to be. So I encourage you to reach out. Feel free to reach out through the chat box if you're interested in getting engaged and becoming part of our leadership. We would love to have as many companies as possible. Connecting healthcare is a really tough thing to do, and it's important to have all the stakeholders at the table. Next slide. We primarily work in 4 critical issue areas. Our work centers around privacy for consumer data, virtual care, lots of that going on right now, and analytics. How do we use all that data, pulling in social determinant of health data, and how do we figure out using predictive analytics and AI what to do with that data? And then finally, I think we've spent a lot of time this year talking about COVID-19, as I think we have all figured out and learned a lot from the pandemic this year. Next slide. Just a sampling of some of our more recent webinars. If you have not been able to attend these, I strongly encourage you to go take a peek at them, listen to them, pull down the slides, look at the transcript, whatever you might do. And this forum here today, then this webinar today, will also be posted live online tomorrow. Not live, but posted online tomorrow if you miss it or want to send it to a colleague or friend. Great sessions and forums available to you. Next slide. This is just a copy of some of the recent publications. We've done a lot of thought leadership and research around analytics, social determinants of health, COVID-19, federal policy, reimbursement, lots of great work. And again, this is available for all of you free of charge to go ahead and download and learn from. Next slide. Couple important dates coming up. We've got a really great program coming up next week on digital health credentials. We try to avoid using the P word, P-A-S-S-P-O-R-T, but we are talking about how do you show folks that you've been vaccinated, and that whole discussion on vaccinations and where that's headed. A really great session next week. We'll also be doing a policy briefing on everything that's going on in Washington, a lot of discussion about what this new administration is doing and what some of those packages include in health information technology, and a great session on patient matching and identity access management on June 30th. So put these on your calendar or register if you haven't already. Next slide. And a big, big thank you to Dr. Lambert and everybody at Curation Health. We are a very, very tiny nonprofit, and we would not be able to put on these educational programs without the really generous support of organizations like Curation, who really believe in our mission and are interested in kind of educating and thought leadership. And so we're so grateful. for Dr. Lambert and his team today. So I do want to thank you guys. And without further ado, thank you for joining us. I'm going to turn it over to Dr. Lambert, who's kind of going to give us a little bit of an intro into what we're going to be discussing today. Go ahead, Dr. Lambert.
Thank you so much, Jen. Thank you for that great introduction, and thank you to Elizabeth Schwartz on our team for coordinating a lot of this. I just wanted to, when I was prepping my notes this morning, I thought I would talk about burnout in general before we focus in on the technology piece of it, because I think we really need to acknowledge a lot of that. And especially with COVID, it's just really hard to overestimate some of the challenges that some of your colleagues and family members or friends or your doctor has even experienced this year. We were heroes for a while in April, and then that kind of waxed and waned a little bit. And then for me personally, as still a practicing emergency medicine physician, the toughest days for me were in January, when we were just really overwhelmed and not really able to provide the kind of medicine that we're used to giving here in the States. So I don't want to underestimate any of that. But burnout has been a part of medicine for a while now. And again, as I was preparing for this, I was reflecting on 4 colleagues over the years, a 25-year clinical career, who chose to take their own life. And it's pretty, you always think about things you could have done differently, or signs that you could have read, or things that you might have done. And there was even one, and there's such a stigma attached with it, which is why you don't do that. I had one colleague who was a mid-level provider who was writing prescriptions inappropriately on my license for controlled substances, and I was forced to take action against it. And the last conversation we had before he took his own life was he thanked me facetiously for taking away his livelihood. So it's the challenges are real. The stigma is real. Another part that really is the nature of the job is tough, and I think Steve will probably talk about prior auth challenges and things like that later on, but it certainly makes a lot of decisions, and it makes sense in boardrooms if you're going to talk about pre-authorization or maybe denying benefits based on because a patient can't be admitted because they didn't meet criteria. But be clear, the providers are the ones who message that to a patient. So a patient might be in pain, they might be suffering from the unknown, their family's concerned, and to be able to be the deliverer of that news is often, for me, I've also been a really tough thing over the years. So burnout is something that I think we should just really make a focused effort to be more thoughtful of moving forward. But the rest of the intro here, I want to focus on what this looks like with technology. And how did we get here with healthcare and technology in the U.S.? We over a decade ago, we incentivized that we were going to adopt electronic health records with a meaningful use bill, a carrot and stick methodology to do that, and it got us pretty far. It made a lot of health systems go faster than they might want to do, which is sometimes a good thing in the change business. It incentivized platforms over niche functionality. And some of the platforms and some of the health systems weren't quite ready for this transition. But that's okay, we got here. And now we see that we don't have quite as many resources. We have some good federal guidelines, but we don't have resources to push these things forward, especially around interoperability. And so we're seeing pockets of innovation come from the private sector to help do this. And it's still moving forward, but it's not at the same pace of change that it was maybe 5 or 6 years ago. When we think about, and that's just technology and healthcare in general, when we think about that through a value-based care lens, value-based care does a lot of things. It incentivizes team level of care. So using a team to care for a patient and to work together, care managers, nurses, mid-level providers, physicians, but it also really puts a premium on information sharing. And so the bar is really pretty simple for me when I'm wearing the scrubs, is it has to be easier for me to access this information, or as easy as it is to get my own. In other words, if there was a CT scan done on a particular patient that was done last weekend at a hospital across town who might be on a different EMR, it has to be just as easy for me to get the results of that recent CT than it is for me to just order a new one and move on to acquire my own information. So it's got to be integrated. It's got to be at the point of care around that. And all of this information too, sharing within value-based care is not equal. There are in a value-based care world, the currency of this is HCCs or ICD-10s, and 55,000 of these have no value in a value-based care world. And so providers don't want to keep track of that. They want to focus on caring for patients. These risk models change yearly. They come out in October, and they take effect January 1. And again, providers don't want to be managing that. So there are a lot of really complex and nuanced things with this information that has value in a value-based care world that we really need to support the providers when they take this transition. Interoperability means a lot of things, and I think it kind of depends on who you talk to on what you mean. Are we talking at the point of care interoperability between EMR to EMR, between Cerner and Epic, or between Cerner and Athena, or Allscripts and NextGen? Does it mean HIEs? Does it mean where we put together some health information exchanges, which at once were pretty robustly funded and really growing? Now those are kind of dialing back. Payer information, bringing payer information to the point of care is a relatively new idea, and it really helps align a lot of value-based care initiatives, whether it be an ACO, a Medicare Advantage plan, a quality metric. So bringing sometimes interoperability means between payers. And then also increasingly social data, right? We're collecting more and more social information on patients, knowing that where they might be at risk in their day-to-day life might present some healthcare challenges. And very often you can make interventions on the social side that pay back 2x on the clinical side. So increasingly we're seeing more social data come in around this. So what are the challenges to a lot of that are we're still getting good guidelines from the federal government around interoperability. We're not getting any funding right now. And I think that's just, the natural waxing and waning of things that happen here in DC, as again, I'm based here in DC. Some electronic health records are reinvesting in this on their own more than others. I think Epic's Care Everywhere is a really good example of a product that is really serving their own needs, but also they're growing to make it to where it can meet interoperability challenges across the spectrum. But not everyone can afford Epic. And again, and you also have to really, it's hard to overestimate some of the gaps and between the payer side and the provider side. We've fallen into a really bad paradigm of providers charging more with the hopes that payers will pay more. And it's really created this dissonance between what is the cost of care, what is the charge for care, and what is the reimbursement for care. So there are a lot of gaps to overcome aside from technology and just kind of getting with interoperability. And then I think lastly, it's at the root of value-based care, transitioning at the practice level, we're asking providers to do something they weren't trained to do with a tool that wasn't designed to do it. So, and I've started to use some messaging when we're working with health systems around the country or practices around the country, of likening this back to the mid-90s. Those of us who are old enough to remember what documentation was like in the mid-90s and how that shifted when we pulled in E&M specifications in the mid to late 90s. I was actually in training, so it was easier for me to do that because my brain was much more nimble back when I was that young. But it's really, it's that big of a change. And again, most of us we're trained in an E&M world, and most of our electronic health records are configured for an E&M output. So I think we really have to focus on training, certainly, and education certainly has a piece of this. But it's only going to get you so far. And we did a lot of this work in previous lives when we were with the advisory board and other things here in town on educating providers on some of the latest trends and some of the things. But wrapping this back into burnout, when you're dealing with someone, when you're worried about burnout, what do you do with them? You support them. You support them. That you would do this for a friend, you would do this for a family member. So not only a support in training and education, but support as a team around them. So make sure that they have maybe someone doing a pre-visit review. Make sure the technology is configured to what you're asking them to do. Make sure you've adjusted your processes to really fit with a value-based care world than a fee-for-service world, because they're very different. And so really always focusing on that people, process, and technology part as you shift to value-based care. And far and away, I think it's always most important to focus on the people and support them through the change. So having said that, I'll go ahead, Jen, and wrap up, and then we'll hand it over to Steve.
Thank you. And I really appreciate you sharing that really moving story.
Yeah, I didn't think my voice was going to make it through that a little bit.
Well, I think, you've shared a really important part. There is burnout and it's very personal, and thanks for doing that. We appreciate that. And I'd love to turn it over to Dr. Waldron, who is with the Family Practitioners, another group of physicians who's had just really gotten a lot of feedback. I think the physician burnout issue is particularly tough this year, particularly around the pandemic, and technology adds a whole nother layer to it. So Steve, welcome and thanks. You are on mute, Steve. We can't hear you quite yet. Sorry.
How about now?
Oh, perfect. Thank you.
Okay, yeah, I wasn't on mute, but for some reason my expensive microphone is not working, but so great. So thanks, Jen. Thanks, Dr. Lambert. I think you hit some great comments. I think you hit pretty much the entire waterfront of issues, it seemed like. But I think that's really important because that's, I think, how clinicians really feel out there, is that there's just all these things coming at them. And I appreciate you talking about the the issues of burnout. I always talking about it being the epidemic before the pandemic, and definitely as you think about the consequences of that, physician suicide at 300 to 400 a year before pandemic is really a key issue. But I think you also could think about it too from all four pieces of the quadruple aim, and it can negatively impact all four of those. From the AAP perspective, our specialty maybe is not the top. I think our urology friends kind of get the top marks, unfortunately, in regards to burnout, but we're in the top quartile for sure. And they talk about a lot of challenges around the clerical burden. They talk about the challenges of being able to transition to these value-based payment arrangements and the issues there. And in the clerical burden, they talk to us about kind of three main big chunks. So kind of EHR documentation burden piece is one key. The utilization management, the prior auth piece that you alluded to is in there. And the last one is kind of the quality reporting piece of that. And I think a lot of the interoperability pieces you talked about kind of lead into those three areas. But on the EMR documentation burden piece, I think some of the changes we've seen with the Inhome coding has started to make some difference. We've been talking with our docs. We have a project at the AAFP trying to drive innovation into family medicine to address these big issues. And we have a product that's focused on the documentation burden. And talking with them, they've also talked about these the benefits of really focusing on the assessment and plan. And I feel like the notes are finally getting back to, it looks like a note that you were telling your colleague, what's going on with this patient? What do you need to do for this patient? What are you thinking about this patient? As opposed to, here's a laundry list of every piece of data that was in the EMR that was put into a note so I can get paid. So I think that's really a cool thing. But there's also some really cool new technology leveraging some of the AI related activities. So we've been working with that and seen like 60% reduction in documentation time and 70% reduction in after hours documentation time, which really starts to get into being able to think about bringing the joy back and also freeing up time for docs to be able to think about all these preventive things that they need to do for these patients or to be able to get better access. So it's really cool. On the Da Vinci side, or on the prior auth side, we've really focused our work in Da Vinci, trying to get that payer to provider communication to work bi-directionally. I think the great thing there is the private sector had kind of stepped up and was starting to do that work before the new rules came out from CMS. So I'm hopeful that will continue to be able to be accelerated moving forward. And that leaves kind of the quality reporting piece. It's really the last big challenge to see significant improvement on. We did a project with CMMI on an AI outcomes challenge to try to think about, could we leverage AI and claims data to try to predict? Because so that could be a way that clinicians wouldn't be required to put in a bunch of data, but you could actually look at the data that you already have and use these fancy algorithms to try to figure out what the level of quality potentially is as a proxy for that. So I think that's really kind of a cool thing to think about. But I would say those are kind of my big comments around kind of the burden. On the interoperability piece you talked about. I've always talked about, we've been able to start to have syntactic interoperability. We've been able to have transactions and move data, but unfortunately, as you alluded to, the user, the clinician becomes the interoperable part. So they actually be able to understand the semantics of it. And I think what's important, as I always thought about it being, we need to get to a semantic level of interoperability. Well, I think now we need to get to that another layer above that is semantics and context. So really, what is this data? What is it? What's it mean? And what does it mean in a constellation with a patient so that you can provide the right type of alerts to physicians and those type of things? So I would say those are some of my kind of initial comments before we get into the conversation, and happy to be here to have it.
Great. Now we're going to bring on Mike Arcoletta, who's been dealing with this in the hospital facility, actually, and with the system, and really from the CIO perspective. So Mike, you're having to actually implement these solutions and try to address some of the physician burnout issues. And I know we've got Mike with us here today. Mike, we can't quite hear you yet, but unfortunately we're not going to have Mike's video because Mike is having, are you there, Mike?
I am. Thank you, guys.
Perfect.
Thank you very much.
All right, great.
Absolutely. So thank you. And thank you very much, Docs, as well, too. So really on some good insights in regards to physician burnout. You know, I'm going to be speaking in regards to some of the technology initiatives that we've done, you know, to really kind of have focus towards this overall process. You know, we always hear, you know, let physicians be physicians, and that's really a key element moving forward. And I think tech innovation can really help mitigate physician burnout. Again, when we're incorporating data management solutions to really help streamline documentation, I think that could really be a huge improvement, especially when we're talking about interoperability and really focusing on different initiatives. I also think with the mass adoption of telecommunicating initiatives as well, I think adopting telemedicine can really leave clinicians with more time moving forward as well. And then healthcare wearables and apps. I mean, if we could implement all of these specific items, especially on a healthcare wearable and application process, this can really ensure overall well-being of our actual patients moving forward. But the problem that we're basically faced in this overall industry itself is the antiquated systems that we basically have. I mean, that's becoming a massive issue with anything that we do. And I mean, creating burnouts from the electronic medical record system, you know, to having interoperability problems, to not really focusing on a lot of standardization and terminology for the normalization of data, which becomes a problem. You know, when we look at interoperability, some of the problems that we're basically faced with, again, too, is standardization and terminology. You know, what are the current standardization processes that we're going to utilize on a technology standpoint? You know, are we using HL7? We're using CDA? Are we using FHIR? Are we using APIs? I mean, there's so many different specific initiatives in regards to this process. And again, the antiquated systems that we basically have in healthcare at times is really a disservice. I mean, when you look at some other industries out there, e-commerce, finance, etc., they've been many more years advanced when it comes to the adoption and the acceleration of digital transformation. But we're doing one of the most important things out there, that's basically taking care of patients' lives. And we're still behind the curve when it comes to those innovations. And why do I bring up technology and tech innovation can really help mitigate physician burnouts? Because when you're looking at this as a whole, we're utilizing technology as an actual tool, a tool to help create better automation processes. Because honestly, when we look at automation, healthcare automation matters more than ever moving forward, especially with the mass numbers of physician burnouts that are basically happening in our industry. And even, again, automating artificial intelligence, solutions that are truly making an impact by streamlining workflow processes and really help reduce clinician burnout is such a critical element, incorporating those technology tools to really create better efficiencies moving forward. But again, those are really important aspects because, as I stated, healthcare is so far behind under other industries when it comes to delivering satisfactory IT-enabled initiatives. And again, I think that is why it's a very difficult industry to really continue to create complexities. And at times, as the physicians were basically stating, especially when COVID-19 basically hit, a lot of these organizations were not ready to basically move forward with some of these. I mean, the foundation, the infrastructure foundational aspects within their organizations weren't built to really, you know, allow individuals to go home, work from home, you know, allowing individuals to implement telemedicine efficiently and effectively, you know, having this overall process. And that is why it's extremely critical to continue to really focus on the reprioritization of IT moving forward, especially when we're talking about, physician burnout, and we're talking about this new model that's basically coming in place, fee for service to a value-based care model. Patient engagement and the utilization of technology and good automated processes are really going to play a critical role for successful outcomes. And that's basically the bottom line, because when we're looking at this industry as a whole, we're seeing the complexities that this industry is creating. We're seeing the acceleration of digital transformation, the mass adoption of telecommunicating initiatives, the importance of having IT and the clinicians involved as a core component to the overall organizational strategy is such a critical element. And health IT infrastructure and processes that basically allow us to share decision makings between physicians and patients is such a critical element in order for us to create success. And again, though, too, is, and of course, this isn't about the consumerism of healthcare, but the bottom line is it's important that we focus on the clinician's decisions, the clinician's ideas, our patient ideas, because in the end, my new CEO is a patient. And that's basically the bottom line. And if we as an organization do not continue to focus and build strong asynchronous tools that benefit our patients both inside and outside of our organization, we will not be successful moving forward. And again, the problem with interoperability in this industry, and kind of going a little backwards, is that antiquated system process. And that's why I continue to basically state the reprioritization of IT is such a critical component moving forward, because this is not a technology makeover, but a business revolution. And the bottom line is IT, innovation, automation, all of these specific items have always been considered an actual cost center versus a strategic revenue contributor, and also a strategic initiative and a strategic tool that creates better automated processes to create better outcomes for our physicians. Better ways to basically ease the burden, as I stated, just by adopting telemedicine, we've been able to, been able to basically help our clinicians have a little bit more time for themselves, incorporating strong wearable technologies to really keep the patients outside of coming back in as an actual patient moving forward. And really having strong data management solutions is such a critical element moving forward from there too. But again, this industry as a whole still has a lot of problems that we really need to focus on. And some of the issues, again, especially on an interoperability standpoint, is fragmentation. I think fragmentation is one of the primary problems that needs to be addressed if these overall electronic health records have hope of being used seriously on a clinical capacity. Because honestly, we've put all our eggs in a bucket, it seems sometimes, into the EHR. And in my opinion, the EHR isn't the center of the universe. We're basically looking outside, creating different innovative ways of basically continuing to provide better, efficient care moving forward, again, with the utilization of technology. And fragmentation really arises when the electronic health records are usable to communicate effectively between each other. And I think that's the overall end goal, sending information, data effectively and efficiently from one system to another. And data that basically matters, which is extremely critical as well. And effectively locking patient information into a proprietary system is not the way of basically doing that. And we've seen a lot of these big EHR vendors really moving in that issue of really having proprietary systems that basically allow these locks for the patients is really a disservice of what we're basically doing. But moving forward, I really think, especially improving on healthcare interoperability, it's really a top priority, ladies and gentlemen, with health systems, clinicians, patients, and even the legislators. I mean, a lot of these new initiatives that are basically coming in to really focus. I mean, one that was coming in and really being reamped was, the proposed interoperability and information blocking rule. Of changing those initiatives, of creating better ways of sharing information in a timely manner and utilizing a specific standard to send it efficiently and effectively. Those are critical elements, and really focusing on interoperability comes down to, again, focusing on care, focusing on patient, trying to really change the overall concept of what we're doing, try to basically remove some of these antiquated systems to create better automated processes, which is such a critical element moving forward. And again, you know, COVID-19 could have perhaps saved the US healthcare industry on a standpoint where the acceleration of digital transformation has really changed. The things that we have done before, the overall, what they call the brick and mortar theologies, are really changing to the overall digitalization and automation processes to really create better efficiencies are really coming in place. And honestly, even as a technologist, it is really an awesome time to really be here and seeing how we have seen the importance of what IT and digital transformation bring into this industry itself. But again, we've seen issues and we've seen these deserviced items, you know, seeing physicians being burnt out with these antiquated systems that really are continuing to be an actual issue. So ladies and gentlemen, we really need to make these changes happen. And again, you know, is really reprioritizing our overall process and creating better outcomes is really the key to success. Because in the end, we want to position our organizations for success. And we really want to make sure that we're creating a very influenced, professional, you know, focus towards our clinicians and their well-being moving forward, and having their overall aspects and their opinions being involved into the healthcare initiatives of what we're doing. And that is why I brought up that specific topic of creating asynchronous tools that benefit our patients both inside and outside of the organization is critical. Having that patient element, that understanding, why are we doing it? If we're not building it for the patient, why are we doing it? So really having those concepts, which I really think have been really left out, especially when the mass adoption of the Affordable Care Act really came out, started mandating these facilities and implementing an electronic medical record system. If not, they were going to be penalized, et cetera. There was very little clinician designs towards these specific systems, and that's become a major problem. So moving forward, my key element is the reprioritization of IT and automation to create better outcomes. Because being a digital health system, it's no longer a question of if or when. We are living in the digital age of healthcare, and we must continue to utilize automation, IT, to create better outcomes and create better successful points as well. Thank you very much.
Thank you so much, Mike. Really insightful. And I'm going to ask Mike and Dr. Waldron and Dr. Lambert to come back. And we've got a number of questions here. It'd be great to run through with each of you. I mean, all three of you talked about workflow and the burden that this puts on all of these new systems and technology and interoperability. One of the things, you know, I'd love for each of you to kind of share with us an example of how the technology can fit into the workflow and actually bring the information at the point of care. So share with the audience here today, you know, what are some actual solutions that are working and are decreasing the burden there? Maybe we could start with you, Dr. Lambert, and then go to Dr. Waldron.
Yeah, I'm going to start on the patient side and then maybe look at the provider side.
Yeah.
Because Mike talked a lot about wearables and maybe managing, monitoring patients where they are. I love the idea of that, especially when I think of a behavioral health patient and just a daily reminder of to take their medication, which is the single best predictor for managing a behavioral health patient where they are. It's inexpensive, it's easy, right? If we can get the same clinical outcome out of a text message, then why are we doing anything else? You know, and again, in a value-based care world allows you to use technology to engage people differently, right? I don't have to set up my operation, so I'm dropping a 99213 ambulatory visit for all of these patients. So I love that. We have to be very mindful of that though, because simply putting more data in front of a provider. So not only am I managing patients in front of me, but now I've got patients from outside coming in. So that kind of goes into that team-based care, right? We need care managers who help to work with that and manage those patients in a way that's outside of the walls of the hospital. So that's patient-facing. When I think of provider-facing, Our two guiding principles at Curation Health are number one, it's got to be good, and number two, it's got to be integrated. So when I say good, if we are going to ask a provider to consider something, to consider a piece of information, it's got to be aligned to what they're doing. We have to minimize false positives. Simply lobbing more data at a provider is just not the way, especially like something like with an NLP solution that's just found one word somewhere and asking a provider to consider it. What do we do with that? And it also has to be integrated as much as it can be. And to Mike's point also, there's a lot of variability in the APIs or the way these things are connected. But the minute a provider, we ask them to go to a separate portal or minimize their EHR and go somewhere else to get other information that they may or may not act on, it's just contributing to the problem. So again, let's focus on patients, let's focus on providers, and how can we get technology to use them? I agree with Mike when he says that this is an investment in ways to deliver care, but we need to be, until the user interface on an electronic health record is as good as my nephew's video game, we need to keep moving forward and keep the clinicians and patients in mind.
Yeah. Dr. Waldron, could you comment?
Sure. So maybe just a comment first before I give a couple of examples. So I agree with kind of what's been said. I would just say, just as it relates to kind of reprioritizing, IT, I completely agree with Michael in regards to that investment needs to happen. I think, though, that we need to focus in on kind of what are the clinical capabilities, right? Because the current technologies, for many times, were not designed for the frontline clinician, or at least they were not designed to be sold to the frontline physician. So we focused on some of our innovations that are really focused 100% on what's that interface. So I think we need to figure out how to make sure we understand what capabilities need to be supported and automated and prioritized, and then prioritize the IT solutions to do that. I talk about it focusing on automating the delivery of healthcare, not automating the business of healthcare, which is what we've been doing for the last 20 some years. So specifically though, to the question about the opportunities. So I think there's some really cool new opportunities that are being levered because of the APIs that have been put into place. So two solutions that we're working with. One is a digital assistant that's voice enabled for documentation. So you just tell the computer what you want to document, where you want to document it. You don't have to navigate into the EMR to go pick things out and put stuff in certain places. You just tell it what you want to do, and it does that. Like I said in my opening comments, we're seeing 60 and 70% reductions in documentation time. Just frees the docs up. The other example that we have that we're working with, it's not as far along in regards to us, I mean, it's generally available in the marketplace, is a digital assistant that will read through the chart and create a clinical focused summary. So it just pulls the data from everywhere and says, for diabetes, here's the data that you're going to want to know. And it actually looks at thing that maybe was categorized wrong. If it came in as a referral from the ophthalmologist and it got put into podiatry, it can figure that out, and it pulls it together and says, here's when the eye exam was done for the diabetic. So I think those are two just prime examples that can really dramatically decrease the burden on clinicians. And without these APIs in place to be able to make it happen, they can't be put into place.
Great examples. Mike, do you have any that you could share?
Yeah, absolutely. So, definitely agree in regards to everyone, as I always basically state, and I open my statement is, healthcare basically has nothing but antiquated systems, and that's an unfortunate thing, and that's been a disservice of what we've been doing moving forward for such a long time. But in the end, though, too, is yes, we need to validate the current technologies that are basically in place. And it's really time for a new kind of electronic health record system moving forward. I think that is such a critical element with the overall success of anything that we do. And I think just with the reprioritization of information technology and really focusing on those initiatives and incorporating automation, incorporating artificial intelligence, incorporating leveraging data management software to keep information consistent, incorporating cloud hosting to really store patient data in order to boost its interoperability across organizations, it's a critical element. And really streamlining the workflow process with the utilization of automation and artificial intelligence into these systems is really important. And that's why I say is really reincorporating IT into the organization's strategy is such a critical element. It's not a technology makeover, but a business revolution that really needs to happen, because we've had these antiquated systems years and years and years, and we've been the industry that has been moving very, very slow pace when it comes to the acceleration of digital transformation. If we basically don't incorporate and bring in these strong tools that create better ways of producing efficient care, this is going to allow us to really help our physicians moving forward and really reducing burnouts or reducing, issues that are happening within our actual systems. And the EHR, again, is such an important thing because it is time, ladies and gentlemen, for a new kind of electronic health record system. The EHR needs to provide the ability for clinicians to really easily analyze patient data to discover new treatments, uncover safety issues, identify usual clinical findings. And if you figure such of these capabilities, if we had this in the EHR, and enabled this, for example, we would have had a faster discovery of blood clotting, even in COVID-19 patients. And again, the specific utilization of artificial intelligence and the ability of creating better efficiencies is such an important thing. And that's why I always say, ladies and gentlemen, is reprioritizing IT, reincorporating it into the overall core component of anything that we do is really going to take us to a much better place. Because honestly, when we look at some of these initiatives, especially going from fee-for-service to value-based care models, technology and the reprioritization of IT really empowers a new era of healthcare, because we know, especially with COVID, that technology has really emerged as a driving force to really achieve success and innovation moving forward.
Dr. Lambert, there's a lot of suggestion that these value-based care models and new models are increasing the burden on the physician and also the patient in terms of what needs to be done. So as you add more data to the system, there are more opportunities to treat them and provide new services, et cetera. Can you talk a little bit about that and, how can you make it's easier for the information to align and appear at the right point in time so that it's not an extra burden, but actually helpful?
Yeah. So once again, I'm going to go way back. My first job out of residency was with Kaiser. And so Kaiser closed the system, right? And for our, and this is before they contracted some other patients. So every patient was ours. It was a closed system. So, and we were using Epic in 2000. So if you think Epic, like Epic in 2021, you should have seen what it looked like in 2000. But it was pretty simple because we could write what was going on, right? As Steve said, we would write communicating to our colleagues, right? Is what we were, is what we were doing to write clinical notes. And then as that grew, when you get outside of a closed system like Kaiser or maybe Geisinger, you get into different coding requirements and documentation requirements for CMS and maybe a different one for payers and those sort of things. It got complicated really quick. So one of the things that I like about going to value-based care is it kind of frees you up from that, right? It's a subscription-based model. So when you have access challenges due to something like a pandemic, you still have steady revenue and you can plan P&L, right? You can make plans farther down the road because you're getting that revenue, and then you can engage patients in whatever fits them the best. Meaning, like, again, that one patient might respond to a text message, another patient might really do well with a video visit, another one might do well with a brick and mortar visit. So it allows you to do that. The problem is that's not a subtle shift, right? That's not a subtle shift in operations. That's not a subtle shift in mindset. And you have to be a part of an organization that can really plan 18 months down the road, because that's how long it's going to be before you see a return. Mm-hmm. And if you're a big health system running on a 1% margin, or if you're if you're a family practice, with 2 or 3 docs and trying to do this alone, that's just a tremendous pivot to make to try to get to a model that fixes some of the current challenges, but probably isn't right. The perfect model doesn't exist. But I think I think it has the potential to free up a lot of this, but we've got to support it, right? We got the same way we supported the shift to the adoption of electronic health records. If we're going to ask the industry, and remember, we're talking about almost 1/5 of our economy in this country. If we're going to ask 1/5 of our economy made up of people taking care of people, then we're going to have to support them through it.
And I think you can really start a virtuous cycle. We saw that anecdotally, some of the practices that we've been talking to during the pandemic, we've been looking at direct primary care, which is a type of value. It's a prospective payment. The patient is the one determining the value. And when we looked at kind of the adoption of telehealth, we realized that those DPC practices, they didn't have to worry about a certain service that they got a fee for. They got paid a subscription fee by the patient to deliver care. So they were already implementing a lot of these digital first kind of experiences, and they were able to innovate and drive that technology straight forward. So I think you're right, Matt, once we support people to make this transition, the fact that we're freeing them up to think about what's the best way to take care for these patients, it really opens them up to say, like, I want to be more innovative. I want to be able to drive that. And I think we'll get that virtuous cycle once we start this process. But it's getting it started that is a challenge for sure.
Well said.
We've got a great question here, a couple actually. So, and Steve, maybe you can jump on this first. So, given all the demands, why aren't providers demanding kind of lighter, standardized, more loosely coupled architecture instead of these massive systems? Comments, thoughts?
Yeah, so I think two reasons. One, they're seeing patients, and in primary care, we got more patients we can see, and I know in ER, it's the same way. So they're just trying to keep the head above water. And the other is they're not the ones making the decisions on what ones to, if they're not part of a medium-sized physician-owned group or smaller, they may have some input, but they're not the ones deciding what systems to build. Epic and Cerner is not, in my opinion, they're not marketing to physicians, they're marketing to the C-suite, because that's the ones that are going to make those type of decisions. So specifically to that question about large systems, that's the problem.
Yeah. I mean, one thought on this, another question here is, and Matt, maybe you can jump on this, is, we've got to make all these changes in technology, and the regulatory deadlines are always, 6 months, 12 months, hurry up and adopt it. So what are your thoughts on that? I mean, what can really be done here in terms of the timeline here to adopt some of these new technologies?
Yeah. Before we get into that, I'm gonna dig on Michael.
Please.
I'm gonna dig on Michael a bit, because when I was a health system CMIO, they always called me Little C, because I didn't have any budget, right? I had a lot of responsibility, but no budget. So to Steve's point around decision makers, that was no, it's really cool to be in between the to be the translator between the technology and the clinicians. It's something that I really enjoy and got a great experience doing that.
Yeah.
Well, if you wait for U.S. healthcare to change, it's not going to. So there has to be something to drive it, right? And that's in any person or group of people or any industry. So there's got to be some sort of timelines to it. I personally prefer. I think this has a lot about your style. I think people will behave the way they're incentivized much better than they will respond to how they're punished. So I think incentivizing the behavior you want is a much better way to make it persist and to make people take ownership of it. I would love to see any, the quality that, and it comes to, I point down the street because the National Quality Forum is just great right there. A lot of things that they incentivize are proven to have good benefit and improve outcomes. So I'm okay with quality measures. I would love to see us get away with any kind of reporting on making sure that you're using the technology, right? Anything that we're doing, and this has been gradually declining over time anyway, but I would love to see us just retire any reporting requirements to see if you're using technology. I mean, that's just, it's time for that to go away. So there's some random thoughts on federal guidelines and timelines.
Mike, I'm going to give you a chance to jump in here because I'm sure you are dying to.
I definitely agree with Doc as well. I think some of the actual burdens in regards to, even utilizing systems in a good way to really reduce basically burnouts is reducing those reporting capabilities. I mean, when meaningful use really came out and started mandating all these clinicians to really incorporate specific percentages, they had to have a specific percentage of utilizing computerized provider order entry, e-prescribing, so on. It really became a burden to add some more additional items to it. But again, I think moving forward with just the advancements of technology, the complexities that we're basically faced with, and really moving forward, is that the more involved and invested patients are, especially when we're talking about a value-based care model, the more involved and invested patients are in their own healthcare, the greater in the likelihood for successful value-based outcomes is really going to happen. I think this industry itself has really not seen a lot of consumerism of healthcare really being incorporated into our industries. And you figure, I mean, consumers are patients. They want, more from their healthcare, pandemic or not. Basically, bottom line. And again, healthcare is far behind other sectors like retail, e-commerce, banking when it comes to delivering satisfactory consumer experiences. And when we're talking about value-based care and the incorporation of technology and making sure that the patient has a center point of really incorporating outcomes that are coming out of your organization, that's really going to be a critical element moving forward. And that's why I say, though, too, is even the EHR itself, the EHR is at the center of the universe moving forward. But I think we've seen a lot of good transformation, especially during this overall pandemic, trying to kind of create better standardization processes within our environment, reprioritizing information technology to really focus on better value-based care initiatives, really looking at data ownership, looking at issues on fragmentation, looking on standardizing patients' last names and addresses, even in the EHR, which leads to more effective matching of individuals' health records moving forward. So again, creating automated efficiencies to create better outcomes and position your organization for success is a critical element moving forward. But when we look at this industry as a whole, it is not getting easier, it's getting harder, it's getting more complex. I think there's a lot of specific barriers, on a political standpoint, especially, that basically stop us from doing specific items. But again, we're seeing the evolution and the change of everything moving forward. And as I state, it's really time for a new kind of electronic health record system and a new time for the new digital era of healthcare as well.
Need to get to a post-EMR era.
Yeah. I mean, one thing I'd love to hear the clinicians comment on is, the whole, in addition to the regulations now, the whole consumer-driven economy now means that patients are in the medical records, reading the medical records, coming into the doctor's office, asking the doctors, what does this mean? Why did you write this in here? Can you talk a little bit about what that means in terms of maybe it adds to the burden, maybe it's just part of the clinician's job, but how are clinicians dealing with that, and can technology kind of help with any of that? Dr. Lambert, you want to jump in first?
Yeah. Let's see. My personal belief, it's the patient's information, right? It's the patient's health and it's their information. And when we talk about all the things that we're asking providers to do differently, to communicate in a way that is talking to their colleagues or maybe another physician who might see the patient and the patient themselves in the chart. I support that. It's the first time you get an email from a patient or an in-basket message from a patient about something you've written, that's a interesting time. Although it also works when you're busy in a shift and the patient holds up their phone and says, "Hey, my labs are back. Can I go now?" That actually kind of helps, that helps throughput. So, so overall, I think it's a good thing. It's created some new ways that we have to document and new ways we have to talk to patients about their information. I'm still also a big believer in withholding, putting a 24, 36, 48-hour hold on a couple of different types of labs to at least empower a conversation before a patient has to interpret something. But overall, I mean, what information don't we share in 2021, right? So I think it's just the natural progression.
Yeah, Steve?
Yeah, and I don't think it has anything to do with, keeping data from patients. I think it's more when folks talk about, and I agree with that it's the patient's information. They should have access to it. That it should be gone freely. There are issues where there's part of the record that's the business record, that maybe needs to be held because of it's important. I mean, I remember back when I was practicing, had a patient that really had really significant problems with mental illness and other things, and if you set him up an appointment with anybody else, it was going to take an hour-long appointment. So we had notes in there about saying, like, do everything you can to open up Dr. Waldron's schedule and put this person on, and do that for, and you shouldn't be done with anybody else. So, how to have that conversation with that individual about saying, like, well, it's, it's because of your illness and stuff like that, that we just can't take care of you any other way. So, that would just be detrimental to have that patient. So there's some of those things. So but I think those are exceptions rather than the rule. But I think the real problems are that you got so much stuff that you're telling the clinicians and the physicians they need to do and have to do, and you're not paying them to do any of this work, right? So now what you said is you have to make this available, and anytime the patient comes back and has these questions, you're not going to pay for audio only visits prior to the pandemic. So you got to bring them in. Well, you can't bring them in because you don't have anything on your schedule today and tomorrow, and the patient's going to be irate. So as a clinician, I'm not going to wait a whole day to talk to this patient about it. So I'm going to call them up and talk to them about it. And then I'm not going to be pissed at the patient. I'm going to be pissed at the system that now I had to take time out of my day to help take care of this patient that I'm not going to get reimbursed. And something else had to give. And it's probably going to be my time with my family or my personal time, or I'm not going to, those are type of the things that I think that really frustrate with them. I don't think it has to do with having the patients have access. I think it's those other issues, and this just becomes a lightning rod for those.
Steve, I mean, what do we do about this? I was on a webinar yesterday, and somebody insightfully said, we get more and more data, but we don't get more time.
Right.
So, I mean, and you just said something has to give. So what do we think it is? Is it a shifting in terms of the work that the, physician needs somebody else with them to maybe spend the time doing that? Is it that, so maybe it's not the physician that needs to be going over all that stuff? Is it, figuring out scheduling so there are longer periods of time? I mean, something does have to give.
Yeah, and I don't know that I have an answer. I think I have a collection of things that I think could be helpful. So you pointed to them. So I think team-based care is critical moving. I mean, it's critical today, and it's even more critical moving forward. And I think there's an opportunity in the technology space to have an AI agent be part of that team and offload some of that type of work. I think there's a need to relook at the business models that we have of how we pay for care and what we value, meaning what we actually pay for. And with some of the value-based things, those prospective arrangements, then we get paid to do that because we figure out, what's the best interest of the patient. And then I think as Matt alluded to, I think there's some technology like saying, okay, well, for this lab, let's put a 24-hour delay, or let's do a special type of alerting to the clinician to say that, hey, this is an abnormal that's going to, in the next 6 hours is going to go to the patient, verify that it, and at least be able to write a note saying, hey, I looked at this. I know it's abnormal in the lab, but it's not anything to be concerned about. Let's set up an appointment to talk. And that text message goes out with the lab. So I think there are cool things that we could do to really support clinicians and patients in this.
Dr. Lambert, I'm going to give you the last word.
Just on that piece. One Curation Health, some of our partners are in-home primary care, full risk, capitated subscription model. Again, not everyone can do that, and it's a big shift from a lot of things. But when you've got 60 or 90 minute visits in the home, then you can manage a lot of these things, right? Yeah. And so they've adjusted their processes to fit this. But again, it's just because it's not dictated by a certain reimbursement model. And so again, and it has its own drawbacks too, in-home primary care, and requires a lot of logistics. But if you're trying to do something like this, then empower the providers to do it. Give them time. Give them 60 minutes. Give them 90 visits. Put four patients on their schedule in a day, and let them go from home to home, as opposed to trying to cram all of this value-based care thinking into a fee-for-service schedule with 15-minute blocks. We can't do both. We can't do both.
So you really think it's kind of a new model of care delivery, really, in
Yeah.
terms of the physician's work. Yeah.
Yeah. It's incentivizing different things.
Yeah. Well, on that note, I want to thank all of our panelists today. I think this has been a really robust and really interesting conversation. I appreciate all of your insights. And I want to thank all of our participants today for joining us and remind you a copy of this session will be online tomorrow. So please feel free to share it with others or reach out to Dr. Lambert if you've got questions. I'm sure he'd be happy to respond to you. So thank you, Dr. Waldron, Dr. Lambert, Mike, Arcoletta. We appreciate it. And everybody have a wonderful day and a wonderful Memorial Day weekend.
Thanks, everyone. Stay away from those cicadas.